How is that? There we go. I think we've got some sound, I hope. So I appreciate Mary for pointing that out. I love the tech. Anyway, love to say welcome to everybody. Dr. Tom here with you. This is really super exciting for me because we are here for Lyme Awareness Month, and this is such an important topic for everyone. Thanks, Andrea, for confirming the sound is back on. What I was trying to say when the mic wasn't working quite right is, if you don't mind just typing in chat where you're zooming in from. Love to know where everybody's from. This is week 4 out of 5. Thanks for being with me for the duration of this. We've done a lot of really good stuff. Tonight, we're going to be talking about cutting edge care. We're going to talk about how we're really going to integrate emerging sort of research advances into our advanced treatment protocols and really helping patients to, go to that next level of healing and health. So really great to see people from Virginia, Vermont, and Illinois, Minnesota. Great. Welcome, everybody. Again, thanks for being here. This is such an important topic because, tonight we're going to really dive into how are we integrating some of the great research that's being done and really change the face of chronic Lyme disease and change the results that we're getting. And really make that huge difference for everyone. And then again, as always, we're going to be hanging out at the end and doing some live Q&A. Always my favorite part. It's great to be able to interact and really go down that rabbit hole and answer the questions you guys have here. So, and again, wow, we've got Colorado, Maryland, Illinois, Brisbane, Australia. I don't know why I was looking at Australia and having a second. I was actually just watching the Red Bull Crankworx mountain biking that was going in Cairns, so that was really cool. Love to be down and checking out Australia. We've got Massachusetts, Sydney, Australia, Northern Michigan, Wisconsin, Jersey, my home state. And I saw Vermont in there too, which is where I went to college. So pretty stoked about that. And so lots of really great stuff. So what I want to do is, without further ado, find out where my little thing went here. And we will switch over. Actually, I have one quick request. If for anybody who's tech savvy and into it, one of the things I had mentioned previous week, our YouTube channel has really grown, and it helps us get this information out in front of the algorithm, helps other people who may not be on our list, may not know about these trainings, to have access to this amazing information to our discussion. So if anybody who's inclined, if you want to click on the link, go over and watch this. It's exactly the same on YouTube. It just happens to have a 10-second delay, so you won't miss anything if you flip over. But what that does is help us get our watch hours up, which helps the YouTube algorithm get this out in front of us. But most importantly, let's dive into our cutting edge care here. We need to make a quick adjustment here because for some reason it is not zooming properly all of a sudden. And what's really cool is this was completely all set up right before we started. So let me try to fix this for us. Don't know what its issue is for whatever reason, but we will get there. It's worked every other night, so we will make sure that it works. There we go. Hopefully that's not exactly where it was right before we started, but we are there now. So let me just go back real quick. Like I said, just a reminder, this is for information, educational purposes. It's a lot of fun. I'm giving you the information that I've looked at, found that it's really, really, the cutting edge of the research. And all this is evidence-based. Whenever it's not, and it's more my clinical experience or that evidence or the experience of my friends, I'll be letting you know. But otherwise, if I'm not already your doctor, this doesn't make me your doctor. If you ever need me to be, I would be happy to hear more about it and help any way we can. Nice to see. I'm checking out in the chat. I see some of my close friends here. Yeah, back in Connecticut from Florida. All right. Nice to see you, Deanna. And so this week, we're a quick recap. We've gone over what to do if we have tick bites. How do we deal with acute Lyme if we happen to have missed that tick bite or we got it and then unfortunately got Lyme. Then last week, we really dove into navigating chronic Lyme, really that chronic challenge, and started to talk about co-infections and some of the effective treatments, both with medications and herbs. And then this week, we're going to really start to dive into this cutting edge care where we're going to integrate really really look at the research that's being done both clinically and in the lab that will help change the way patients recover more quickly, and also how clinicians are able to practice medicine. And then next week, we're going to do, instead of our typical Wednesday at 8 p.m., we're going to do Thursday, June 6th at 8 p.m. We're going to be talking about fight, flight, and freeze and how to overcome that. Kind of like an amygdala, limbic system, vagus nerve retraining session where I'm going to go over some of the evidence of how to move yourself forward through this. And then also we're going to end that with a live healing session where you're going to really experience this. So if you're a clinician, you're going to learn not only firsthand what it feels like, but you're going to learn tools you can share with others. If you're a parent or a partner, a loved one of someone who's suffering, this might be a great, maybe they're not in the right place to do it right away. I'd certainly ask them to dive in, but also if you do this, then you can learn these simple techniques and slightly more advanced techniques to really help them start moving the needle forward. So let's keep on moving. I'm excited. One of the things I shared last week, and we talked about a couple of times, is a lot of the natural treatments are really coming to the forefront to help us move forward. But the question is, where are they working? Who are they working on? And are they working on the growing or the stationary forms, or kind of that rapidly growing form, or that's metabolically active, the kind of the active infection part versus these persister forms? And so I just wanted to throw this up and say, hey, this is available for anybody who wants. If you just head over to originsofhealth.com, you'll be able to pick that up by going over to the free resources section. Just dangle over that for a second. Top 5 supplements for Lyme will come up for you, and it'll be completely free of charge. And as you can see, that's right there. So you'll be able to grab that if you haven't done so already. So to really kick off, and Jim, thanks. That YouTube link is 2 above the comment that you just made there. So that's right up there. And let me see if I can even post it again. I like easy. There we go. All right. So, one of the things that I wanted to really start off tonight with was disulfiram. My great friend Ken Ligner, really somebody who was, it was and is a forerunner in this field, always pushing the envelope, but for, the patient, but he's also somebody who's very evidence-based. So he's not just kind of going by the seat of his pants. He's really diving into this. And, Kim Lewis did some work saying that disulfiram may work on babesiosis. Then there were some papers that said it might actually have some anti-Borrelial or anti-Lyme properties. And in one of his patients asked, hey, can we try this? So very cautiously and really monitoring things, he looked into disulfiram and started to see that it would make a difference in patients, right? And so then he published right up here those first 3 cases. So and that really kind of turned the tide in some of our chronic Lyme patients, and we started treating it. Now, one of the things that we'll see up here, if I can move my thing real quick, is, there are some patient-reported toxicities, which we're going to go over. So when you're treating late Lyme, you have to understand how to use disulfiram, what to be looking for, and we're going to talk about that. And then also the other part here is there's been some other studies, or I should say papers that have come out by Dr. Grout and Mitchell, really just talking about, hey, it's important when we're going to use these sort of advanced treatments to look at mitigating side effects. And so they're all published in the medical literature, and we're going to kind of go over all of these tonight. So one of the things we thought about in the beginning, and this is where, because, Dr. Ligner didn't know where to start, is, hey, disulfiram is usually used to help people who don't want to drink. It's also known as antabuse. If they take this medication, then they take alcohol, they'll get really sick, nauseous, heart palpitations, sweaty, probably vomit, maybe even have diarrhea. So it's pretty uncomfortable, and that's why it was successful. So what we did know is that in alcoholics, we could use a dose of 500 milligrams daily. That was kind of our target dose. And initially in the work, we kind of were looking at doing 6 to maybe 12-week treatments, right? But over time, we realized that some patients can't handle that. And then they started at 250 milligrams once a day. And then we were trying to get that to increase by maybe 125 or 250, every week or two if they could tolerate it. But then we found that a lot of people don't tolerate that. And some people needed to go as low as like 225 milligrams every other day, every 3 days, and then slowly titrate up. But that original feeling that we needed to get to that 500 milligrams, like, it just turns out that everybody's an individual, and we do need to do this a bit differently for just about everyone. So this is really exciting, because we know that we can, if you have somebody who's robust and they can handle more, go for it. If there's somebody who needs something, a little lower, they can still get better. And there's a lot of people who do really well on, 25 or 37.5 milligrams every day or every other day. And that makes a huge difference for them. Some people, and a moderate amount of people, probably about 15-20% of people in my practice, really benefit from an enteric coating, meaning like you get it compounded, and anything really under 250 milligrams, you're going to have compounded anyway, unless you're really good at splitting the 500 pill into quarters. But it's that enteric coating that kind of just gives it's a little easier on the stomach, and some people do need that, so keep that in mind. And so really, this is kind of what I talked about. Sometimes we don't need the higher doses. We talked about this last week when we introduced tafenoquine, is you don't necessarily need to go to these monster doses, and some people do really well low. And some of my patients, like, who are really toxic, really sensitive, we start low, we work them up. It might take, 8 months, a year and a half to get them to tolerate even a normal dose, quote unquote, normal standard dose of something. And then you can go higher if you need to. But a lot of times it's that low and slow that really can make a really significant difference. Big things with methylene blue is definitely with disulfiram, is to, make sure that you're not using alcohol with it. This includes drinking alcohol. This includes mouthwashes that include alcohol. Some people can have some really nasty reactions to that. This also includes, for a lot of our herbal tinctures. So a lot of the BioPure, Woodland Essence, Lime Core Botanicals, when you're using those single herbs that we've talked about and that are even summarized in that top 5 supplements for healing Lyme, they're an alcohol base. So we want to go away from that. And then even a lot of our glycerin-based products, be careful, read the label, because what they write glycerin on the label, it'll be glycerin and alcohol. They kind of half the amount of alcohol. Things like Beyond Balance, they don't have alcohol in their formulas, so those can be used really well. But a lot of times we are going to have to move away from that. Some people, I've seen it very, very rarely, maybe one person. I've heard about 3 or 4 total, where even an alcohol prep on their skin can be bothersome. So they may just have to wash their skin or use betadine, if you can find it without alcohol in it, to prep for even a blood draw. You're also going to have to check things like the liver function tests. That's what LFTs are. In the beginning, we really want to do it at least every 2 weeks, sometimes more frequently, maybe even weekly, depending upon their response. I typically put people on liver support. R-lipoic acid or alpha-lipoic acid are really helpful. R-lipoic acid is just sort of that active isomer of ALA. So instead of getting ALA and RLA and SLA, we just get the RLA. It kind of cuts to the chase, but either one work. NAC can be really helpful. And there's a myriad of different liver supports out there, a lot with mushrooms, a lot with NAC and ALA already in it. Just be careful here. A lot of the stuff that I typically use is alcohol-based. So when I'm using disulfiram or something similar, I need to move to some of these other ones. The big side effect of disulfiram, if outside of the alcohol situation, would be neuropathy. And it's really like numbness and tingling. And I've seen it in a handful of people, and it tends to creep in really slowly. So if you're like, oh, my feet are getting a little tingly, this is very much like diabetic neuropathy. So it's going to be on the really long nerves, start in the feet before the hands. So, but if somebody's feeling like they're walking on rocks, sensation in their feet and stuff, that could be, then they didn't have it before. That could be the beginnings of this. So just be aware of that. We really want to monitor closely. If it starts, stop. If it's really full blown when they talk to you, definitely stop. I use a lot of B complex and glutathione to help reduce the risk, but we can't 100% reduce it. So you have to monitor closely. But a lot of these things that could lead to neuropathy, like disulfiram, or things like tinidazole or metronidazole for the Lyme round body form, I have people avoiding alcohol, and I have them on a higher dose B complex to start, along with that glutathione as well. And just remember, in alcoholics, disulfiram is known to cause this. It can take a month or two to recover. I see this in Lyme patients as well, and I've seen a couple people where it's taken them 8, 12 months to recover. So there's probably something about it where, we're already behind the 8 ball and we're taxing their system more. Maybe they had some nervous system involvement already. So just be aware and really really be right on top of this. If you see it starting, stop it. If you're a practitioner, if you're somebody taking it, I would stop. I would, call your doctor, obviously, but probably stop it and not take another dose until you talk to them if you see neuropathic symptoms starting. So disulfiram is really one of those kind of, for some people, 5, maybe 10% of people, game changing. It can be a little hard, but if you get it right and you work with a practitioner who knows what's going on, you can use it very effectively. The other one that's really come out from another good friend of mine and a mentor, someone who obviously probably doesn't need any introduction, guru, trailblazer in the field of Lyme disease, is Dr. Richard Horowitz, who's been doing work with disulfiram. This is an anti-leprosy agent. They found that it had anti-Lyme properties, particularly having some anti-biofilm properties, and there you go. And they started investigating it a little bit further. He has come out with at least 4 papers, 3 of which are here. We've got more coming in just a moment. And really looking at this effect of dapsone, whether it was by itself or in combination with other drugs, in vitro, meaning like in Petri dishes, looking at Lyme biofilms with Dr. Shappy, looking at single dose, which is kind of your standard leprosy dose at about 100 milligrams a day, double dose dapsone, 200 milligrams a day, and then comparing like longer and shorter courses of higher dose dapsone therapies and such. So what's really interesting here is I have seen dapsone work really well at 50 milligrams twice a day for 6 months, along with doxycycline and nothing else. And, basically I had a patient who stopped following up, and then 6 months later he comes back and he's just like, oh, I just got to check on my cholesterol and get my regular, primary care labs. And I'm like, what are you doing? And why aren't you on dapsone? Why haven't you followed up? Like, I'm all better, And then there's other people who need double and triple and sometimes even pulsed quadruple dose or 400 milligram doses. So we're going to dive into a little bit of that. The challenge with dapsone for me is this is sort of the protocol basics. So you're on dapsone, doxy, rifampin, methylene blue, leucovorin, which is folinic acid, plus L5-MTHF. So, we're bypassing multiple stages of the methylation pathway of folate so that we make sure that you're getting this. We know that dapsone is very much like Bactrim, but kind of souped up. So it can, use up, it inhibits folate synthesis. So there's a lot of stuff going on here. We have to stay on top of the B vitamins, particularly the folic acid. The activated forms, I should say. We need some glutathione and at least 3 probiotics typically, mostly because we're on a gazillion different things here. So when you look at this protocol, I look at it and I go, okay, well, we've got Lyme covered here. We've got Lyme covered here. We've got a combination here that could hit Bartonella. And then if we had methylene blue in, we're helping treat Bartonella and we're also helping treat Lyme. So there's a lot going on here, except we're missing out on babesiosis. Now, with that said, this is kind of the original kind of basic starting point. Other antibiotics can be substituted in, but that's the starting place. And typically what goes on is, 25 milligrams a day for a week, then 50 milligrams a day total for a week, then 75, and then 100. And then once you get through that first 4 weeks and you get to 100 milligrams, we bump you up to 200, and we do that for 2 months. Most of the time, I find that I need to extend this and do week 5 through 8, kind of going by 25 milligrams and then graduating to the 200. A lot of my people don't like to take that big jump. They have big flares. So where the kind of the guideline, the original protocol is kind of a 3-month protocol, I typically end up doing at least 4 months. And you'll see that a lot of people need longer courses. Before you start this, you got to check for a thing called the glucose 6-phosphate dehydrogenase deficiency. Basically, if you have a good level of G6PD, you're going to probably be fine. If you don't, you're going to get hemolytic anemia. This will lead to the use of dapsone, especially at these higher doses, is going to lead to things like, folic acid deficiency related anemias. So we need to use leucovorin and methylated folate in pretty high doses. The one thing I will say about this is I have seen that people who run out of their methylated folate, the L5-MTHF, they go to, maybe like CVS and pick it up while they're waiting for it. If they don't have enough folate that's activated in that activated form, they become very anemic. So it's really important to stay on top of these. And later on in the protocols, you'll see even our leucovorin is going to get to 3 times a day, and we might be on 60 or 90 milligrams of methylated folate, right? So everybody out there who's a little bit concerned about, 800 micrograms or 1200 micrograms of methylated folate, we are like way beyond that for this, and it's required, right? And then at higher doses in particular, pretty much over 150 and almost guaranteed over 200 milligrams a day, you're going to get methemoglobinemia. So we really do need to be monitoring those complete blood counts, the CBC, and those methemoglobin levels. Methylene blue can help minimize this, but it still happens. And methylene blue is a treatment for hemoglobinemia. But when we're using these higher doses to really help people move the needle in their symptoms, it's a balancing act. So we have to be careful. And then really, that's where a lot of this got started. We were either doing 100 milligrams a day or 200 milligrams a day. And then both Dr. Horowitz and I know I started to see this in my practice. I had some people who were doing okay, but they needed more. They did that protocol, they got better, or they got to the top of it and they just, they weren't all the way better. So then we were doing things like 300 milligrams a day or 400 milligrams a day. But at those doses, people can barely tolerate it for 4 to 7 days. So it ended up kind of being more pulsed because, you would get people whose pulse oximetry, their oxygen saturation would go from something like, 97, 98 all the time, and then maybe on 200, they might be 94, 95, 96 to like 82 on quadruple dose, like in 4 or 5 days. So you would obviously have to stop and let it rebound. And that's how we got into pulsing, right? And so really, this is kind of, a really important paper that Dr. Horowitz put out is really that short-term use of high-dose pulsed, essentially quadruple dose dapsone in combination with other things to really kind of hopefully finally move that whole needle, right? To really make that happen. And so we've got these treatment results, right? Where when they did this case series of this review of 25 patients, 21 of them showed improvement from their tick-borne symptoms. And then only one person had real significant worsening after they stopped. So if you're moving the needle for 84% of people, it's something you might want to think about. Now, when we dive into the rest of this, we have to, look at it and we say, hey, who's completely fixed, right? Because the big thing is a lot of these things work for a little bit of time. So in this study, 8 of 25 people had resolution of all Lyme symptoms after treatment for at least 3 months and some longer. I put that emphasis in there on the quote because I think it's important. Some people were short on follow-up by the time of publication, but there were people over a year, including people who had had symptoms for over 20 years unresolved that more than a year after this treatment were symptom-free. So it's important to understand that this is an individualized treatment. You have different responses, but certainly when we can show some significant improvement, including symptoms of all these other, that have been chronic for potentially a decade or two, I think that's really helpful. And one of the comments I see right now is Roberta's taken some dapsone with good effect. What's really interesting to me is like, I have some people who it's taken them like a year and a half to get to like 150, but their symptoms are great. Now we're trying to get them higher so they can come off. But the biggest problem is when they come off, they don't do well. So we're really just working our way up, but that's an individual, right? And I have another guy who the only thing that's worked for him in like 6 years that hasn't led to vomiting of blood and all kinds of weird systemic symptoms has been 4 days on of high dose dapsone and then coming off. The challenge, though, I will say with high dose or quadruple dose pulse dapsone is this slide from Dr. Horowitz's paper right here. They're saying 2 days before we start, we're going to methylene blue, 50 milligrams twice a day, not in a completely unreasonable dose and continue everything else you've already been doing. But we need to go to biofilm, lots of biofilming agents, and some of these are the ones that we reviewed in our last lecture, where we said, hey, one lecturer said, hey, we're a biofilm agent, one paper said it was, one paper said it wasn't. These are really low risk agents, so that's why a lot of them are combined, and we continue to use them that way. But you need triple biofilm agents, triple probiotics, and then we need NAC, alpha lipoic or R-lipoic acid, glutathione, and typically a lot of us are doing liposomal glutathione 250 milligrams twice a day, maybe 500. These people are getting 4 pills of essential pro glutathione, or the liposomal glutathione from like Pure Encapsulations, to make these doses. So this is right here, this is a huge protocol, already. But then, days 3 and 4, you got to bump up your methylene blue. Then we go on our doxy. Then we go on our hydroxychloroquine or Plaquenil. I did leave that out on that previous slide. I typically do leave it out, but it is used to alkalinize the intracellular compartment and help drugs like doxycycline and rifampin potentially work better, because they're going to work better against these pathogens in an alkaline environment rather than a more acidic environment. But then we have our rifampin. We add nystatin to help minimize yeast overgrowth. We add that dapsone, on days 5 through 8 at 200 milligrams twice a day. So that's 400. Methylene blue is up to 100 milligrams twice a day, and then that leucovorin is there, and they're taking 75 milligrams twice a day. So it's then we're adding more folate, right? So like I said, more folate here, 45 milligrams twice a day. So I was saying, you need 30 milligrams minimum twice a day. And in Dr. Horowitz's work, he even does more. Now, here you go. We're now at 8 capsules of glutathione twice a day. Or if you're on the pump ones, half a bottle twice a day. I mean, this is a lot of detox support because it's required. And then after that, so they've got their 4 days there. Then they stop everything except the methylene blue, the leucovorin, keep the same supplements. Then we start to decrease, and so on and so forth. And this is your pulse, right? So this is the pulse for the times 1, and then you figure out who needs what next. But this is really an important thing to remember, is if you are considering this as a practitioner, sharing this with someone else, or you're considering it as a patient, this is an intensive protocol, and you really do need to do everything here. Now, could you probably get away with a little less glutathione if your Herx isn't that bad? Sure. Maybe you could get away with RLA or ALA instead and by itself without the NAC. Would I risk it? It's probably not worth it. Do you need all those probiotics? Do you need all that leucovorin and that L-methylfolate? Absolutely, 100%. So where you could kind of move a couple things around in this protocol, you're not really able to take a lot away. So just that's one of the things. And then, most people are going to feel like dirt by the time they get done that day 5 through 8, and then they'll recover. So just be aware. The thing is, with dapsone, I've seen effect at all kinds of doses. And again, like I said, the responses are individual. The overall protocol can be very complicated. Part of it is there are significant potential for side effects, from the methemoglobinemia to the hemolytic anemia, to just severe Herxheimer reactions. Lots of things to be aware of with it, but it can be a game changer for some people. In my practice, I haven't seen it be like the be all end all holy grail, but certainly for a lot of people, it's made a huge difference. And like the one person that I talked about last week, and I alluded to a little earlier, who was on methylene blue, really low dose for like a year and a half, we eventually did double dose dapsone with exceptionally high doses of methylene blue. But almost all those antibiotics that he had previously not been able to handle, he could handle. But it took me 18 months to get him ready, and a lot of patience on his part as well as mine by doing this low dose prep. So just because it doesn't work for you in the moment, maybe we need to, be prepared. And that's one of the things I'm going to share a lot with next week is how do we prepare our body to receive treatment? And how do we continue to support it along the way? So definitely something that to keep in mind. And for me, there's not enough evidence to say this is a starting place, right? Because essentially everybody who's been studied has already been under extensive treatment. Now, the other thing about this study that's really important to understand is some of these people were also on disulfiram at the same time. And so anything in this list that had alcohol in it, they used something different. And that's why you see the cinnamon, clove, oregano oil here after stevia, right? And so it's important to understand this is one of the things that may be really important in moving the needle forward for some people. And it should probably be considered in a lot of people with chronic Lyme. But my personal opinion is start with the basics and then move to the really advanced things, both as a patient and as a clinician, because all the people that we were talking about doing better had previously been started, had some of their infection load treated with other things. And this is, for a lot of our practitioners, this is a super daunting thing. And it's one of the most asked about protocols in my world. So I have a lot of practitioners coming to my training program just because they want that in-depth training where we can dive into how do we not only read the article that Dr. Horowitz put out, but then how do we actually implement that in real life with real patients, and how we get that real-time feedback. And that's really what direct mentorship and community support is all about. So for any practitioners out there, if you want to check out a more in-depth dive into how to use things like disulfiram, dapsone, and make sure your fundamentals are strong, and no matter what happens, have myself and a community behind you, check out the LDPC or the Lyme Disease Practitioner Certification Program. Love to talk to you about it. Really, it's designed so that when you look at something like that and you go, oh my God, I don't know how to do that, and I'm a little afraid to do it with people, is that we've got your back because I've done it, others in our group have done it, and we're really there to help support you. So one of the other things I really wanted to, talk about here would be looking at tefenoquine, because this is a treatment, for babesiosis. And I think it's really important that we remember that before I do that, I just want to make a quick comment based upon something I just saw in the chat here. Please be aware that all methylene blue has heavy metals in it. If you go to, I do not personally recommend going to Amazon, because if the price is too good to be true, it probably is. The challenge is a lot of the products that are being recommended by practitioners and are advertised online show almost none to no heavy metals. That, to my knowledge, is not possible. Now, we don't want to be getting commercial grade or cleaning grade methylene blue. There are a couple of people who died during COVID because they went and started playing around with that. But the important thing to remember about methylene blue is it will have some heavy metals in there, which is another reason we want to be on these detox protocols while we're doing it. But you can't get away from that. For me, the best prices that I've heard of in a very long time, by a long shot, are at InfuServe America. More recently, in the last 6 weeks, I've heard there are other places that have had similar pricing, but the pharmacy needs to buy huge amounts of bulk to get it properly. So personally, I also like capsules because my patients don't like their mouth blue. If you are looking to cut costs, personally, I wouldn't do it for methylene blue. I would look somewhere else for my own body or my family's body. But if you are looking, I just had this conversation with a naturopath who's a dear friend of mine who treats Lyme up in northern New England yesterday. The big thing is, if it says there's 0 toxins on a third-party data sheet, they're lying, right? If they show trace amounts of multiple different things, there's a chance that that's actually accurate. The reason I say that, I just want you to know that, it is important to understand. I've done super in-depth dives on methylene blue. I've been lecturing on it for years. There's no way to get it completely clean. If there's a new way to do it and somebody finds that paper and we can prove it and then prove it again, please share it with me, because I'm always open to learning. But after spending years looking at it, it's just, in my mind, really important to understand that if it looks too good to be true and it's ultra pure, it's probably too good to be true. And it's important to think about too, because when you look at the things like tefenoquine that's been sitting on the screen here, we may need to use methylene blue here. So we might use methylene blue for Lyme. We might use it for babesiosis. We might use it for Bartonella. So for different reasons, right? And so here we've got tafenoquine, because babesiosis is something we don't hear a lot about, right? We hear a lot about Lyme. We hear a lot about Bartonella, and everybody's like, wow, babesia is hard, but we don't know what to do about it. We did have that, study we talked about coming out of Johns Hopkins, where they found that things like Cryptolepis and Chinese skullcap, and those were really good treatments for Babesia duncani, but we don't know for Microti. So anyway, tafenoquine is an antimalarial drug. It was FDA approved somewhere around 2018 for the treatment of malaria. But there are some cases out there where actually resistant relapsing babesiosis in the standard medical literature was treated with it. So I wanted to kind of dive into that a little bit. And one of those things, this is really interesting. This is a 36-year-old guy, previously treated with immunosuppressants, but was not immunosuppressed at the time that all this went down. But he had active babesiosis, and he was treated for 10 days with a high dose of azithromycin, which I think is the right dose, at least for the first. I'd probably kept him on 500 the whole time. But atovaquone, also known as Mepron, which is the combo of those two, is standard of care for Babesia treatment. Problem is, standard of care is atovaquone twice a day at 750, not once a day. So the dose is a little low in my mind. But then, so they treated him, stopped the treatment. Then he got fever, night sweats, muscle aches, chills, and a repeat blood smear was also positive. Then they kind of put him on a normal standard dose of treatment. And then this just went on and on and on, and they just, treating him longer. And how many of you who have Babesia went to a standard doctor and they treated you for 94 days? Like, no one, right? But they give us crap for doing it. It's kind of crazy. But then they give another 20 days, and they name 14 days. They added in clindamycin, which is another treatment that we talked about last week for babesiosis. Then we went on and we said, hey, then they just kept with that. But look at all these numbers adding up: 10, 84, 20, 14, 45 days. Now we're another 47 days, right? And after this is almost a year here, pretty much a year. Then they decided to go over here and they added higher dose azithromycin. They decreased the dose of atovaquone because not only did they continue the Clinda, but they added in Malarone, which 4 pills of Malarone would be 1,000 milligrams of atovaquone. So the dose is actually pretty decent and high, but they were still having issues. We need to do something different. So what they did is they added in tafenoquine and reportedly cured him, and he no longer had relapses of babesiosis based on symptoms or blood smear, which is great. And, they said they ended in April 2020, and this was published in 2022. So there was some time for him to become symptomatic again. Now, let's dive into this and talk a little bit about this, because to me, 6 weeks of tafenoquine is pretty exciting if you can get the job done, right? One of the things that people studied, and I think is really important to understand, and granted, this only came out in September 23, but when we figure out the dosing that reduces parasitemia in a mouse, and then subsequently make human doses, what we did was we looked at 20 milligrams per kilogram in a mouse to find rapid reduction in parasitemia. And that dosing there's a bunch of other studies that show we should be there. The important part for us as human beings is that the current dosing, which was at 200 milligrams 3 days in a row, followed by 200 a week, is gotten. We humans will get the same blood levels of tafenoquine if we use that dose, right? So essentially, what we're saying, if I go back, I hit the wrong direction, is the mouse needed 20 milligrams per kilogram. We are nowhere near 20 milligrams per kilogram, but we are getting the same blood levels as you could measure in the mouse that got rid of all the parasites. So we may not need to go to crazy high doses. Then earlier this year, in January 2024, we saw that tafenoquine atovaquone combination not only cures Babesia microti and Babesia duncani, but it confers sterile immunity, meaning of Babesia duncani. If we re-inoculate a mouse after treatment with Babesia duncani, it's essentially like it has been vaccinated against it. Now, we didn't give him a vaccine. We just treated him for the infection. So this is a really, really interesting study. The other thing, though, that's super interesting to me is they use half of the dose of tafenoquine that we were using in the mice to get our current recommendations for humans. So now we're even showing we could potentially get away with a lower dose of tafenoquine if we added atovaquone with it. And at this dosing, if you had a low to moderate amount of Babesia microti, it would be eradicated. If you were inoculated with if you're a mouse and you're inoculated and you had a high load of babesiosis, you would need to add the atovaquone. And across the board, if you had Babesia duncani, you would need to use this combination of both, because it would come back. We would see there it says no recrudescence. Recrudescence is essentially relapse or of infection, finding those parasites around. So if you had Babesia duncani, you needed to do both. If you had microti at a low level, you needed just tafenoquine. If you had it at a higher level, you needed both. So pretty awesome to be able to use the word eradication and never come back. So the question is really, what dose should you use? And I just want to point out, if you do 200 milligrams 3 times a day, and then once a week, you're going to get plasma levels that are similar to the 20 kilogram mouse. But I just told you we're here. We were actually using 10 milligrams per kilogram in mice and eradicating. So some of these higher dose protocols may not be absolutely necessary. In some people they could be, but just keep that in mind, that it's more about using the medicine, using the right combinations than anything else. And I throw this one in here. I think this is really important. A lot of infectious disease research is done where people with Babesia or Lyme or anything else who are immunosuppressed are sort of our poster child for, does it work? Because when you're super immunosuppressed, like with these two medicines here, the rituximab and the bendamustine, when you look at those and this person is profoundly immunosuppressed because they're treating this lymphocytosis, and they have to. These are not normally functioning immune systems. Essentially, they're people where their immune system's not working almost at all on purpose to keep them okay. So they should be the hardest of the hard to treat. In this report, they did a loading dose of 300 milligrams on day 1, and then they were going to do, when you read the paper, 300 for all 3 days. They decided, based upon the clinical response, to go down. This person essentially got 600 milligrams over 3 days, and then they did 300 milligrams weekly. And this is a profoundly immunosuppressed person only on 300 milligrams weekly, right? Just a little bit higher than that 200 milligram recommended dose. So this is just going to help guide us when we go to dosing. Tafenoquine gets really good blood levels really quickly. One of the benefits of it and the risks of it is it's got a really long half-life. So once we get to the right levels, it can stay there for a couple of weeks before, the dose in your blood goes down by 50%, which is what a half-life is. And just like atovaquone, tafenoquine is much better absorbed when you take it with fatty food. So have a nice fatty meal that once a week when you're taking it, and that'll help the absorption go way up. And that's something that's not really controlled for in these studies, but let's give ourselves the best chance to have that. One of the things I think is important too is to say, what are we using it for? What's it approved for? Because so much of what we do is not approved for what we use it for, but we have other approvals and we have to go back and look at it. And I mean, the entire medical community, not just people treating Lyme and other tick-borne infections, right? So it's approved for malaria prophylaxis and treatment of really resistant Vivax and Ovale malaria. So radical cure is really something, or the word eradication are words we like to use in infectious diseases, because these are malaria has been known to be persistent too. So this is really helpful. The other thing is, this is not approved in the United States to use in children for any indication. However, there's studies showing safety and efficacy in really young children, ages 2 and up, and the Australian Therapeutic Goods Administration, essentially our FDA, has approved this for children over 2 years of age. So, and that Velez paper down there from 2021 highlights a lot of the data that can help us understand that. But just know that there is research across the globe showing that this is safe even in pretty young children. I think it's important whenever we're using anything like this that we look at, do we have side effects? Well, to me, the challenge is always, is it a medication side effect or is it a side effect of killing the pathogen? So dizziness can be from the medicine, and it can be from killing Babesia. Nausea, vomiting, diarrhea happens almost anytime you put a pill in somebody's mouth, as well as if you kill a parasite. Although Babesia might be a little less vomiting and diarrhea, but certainly could do nausea. Abnormal dreams are something that can happen quite a bit with any Babesia treatment or any malaria treatment. A lot of it is felt to be related to the drugs because some of the drugs do it really commonly and some rarely ever do it. The other thing is symptoms of depression or anxiety can be important ones in tafenoquine. But again, like we talked before, depression and anxiety of a severe degree that's acute and associated with infection can be Babesia more than, say, Bartonella. So this could be a die-off or a side effect of medicine. And then we have back pain, which could be either increases in liver functions. You could be killing off stuff, plugging up the liver, or it could be the medicine and its metabolites. And then headaches, again, are often a Babesia thing. So just keep those in mind. And those are some of the common side effects. There are also eye and especially retinal issues that can come up. There's not a lot of, they're not super common, and all the ones that have been reported in the medical literature will resolve once the medication's been discontinued. So I think that that's important, but just if you're on it or you're going to put somebody on it, just keep an eye out for eye things. Now, two of the most common side effects that I see with tafenoquine are fatigue and brain fog. And the reason I pull them out separately is that a lot of times the medicines that we're using are not just directed at one thing. And there's a paper showing that tafenoquine has broad spectrum antifungal activity. So how many of our Lyme Babesia patients, don't also potentially have yeast overgrowth from chronic antibiotic use, from dietary problems that happen, maybe before they really got health conscious, their diet wasn't that great. And then the other thing is how many people are exposed to mold, which is also a fungus, just like yeast. So we could be treating candida with this, yeast with this, we could be treating mold with this. So be aware that some of the side effects could be not related to killing Babesia and not related to the medicine directly, but indirectly because we're killing off other things. So keep an eye out for more research here. I think this is 2022, so we haven't had follow-up on it. So hopefully you will start to see some more soon, but just beware, tafenoquine actually can kill some fungus. Other things that we'll see that the docs will pick up on labs, we can see, especially at higher doses, low hemoglobin. We can have hemolytic anemia, and then methemoglobin. Pretty much, I've seen it probably in about 5% of people below 300 milligrams or less total in a week. But when people are in higher doses, we see it more. Can you see it at lower doses? Absolutely. But just keep in mind. So one of the things I would look at if I were a doc or a patient doing this is one of the first things people start to do is get fatigue and brain fog when that happens as well, right? So one of the things we do is get people before they start this to put a pulse oximeter on, know what their oxygen levels are, because methemoglobin will bring, if those levels go up or if your hemoglobin levels go down, you're going to have decreased oxygen carrying capacity in your blood cells. AKA you're not going to have enough oxygen, and you'll be able to start to monitor that kind of in real time with the pulse ox. Contraindications or reasons we really shouldn't use this, kind of the absolute one is allergy to it from trying it before, or G6PD deficiency. So if that glucose 6-phosphate dehydrogenase that we had to look at for dapsone is low, you're also tafenoquine's out because you're going to get hemolytic anemia right away. Pregnancy, we typically don't want to be trying new Babesia treatments and any new treatments in pregnant people until it's studied more. However, relatively safe. The big problem is later in pregnancy, G6PD can fall, so you could potentially use it earlier on. You'd have to monitor the levels, something you don't necessarily want to get into, but if it's necessary, it's possible. Active psychosis, you should avoid it. People with history of psychosis, things like the hallucinations, all that disorganized behavior, being delusional, these are things where you might want to avoid it. Or if they're well controlled, you just got to talk to the psychiatrist and them and really know that this could get triggered by, one, the treatment of Babesia, which you're definitely going to want to do, but also directly from the medicine. And then we have this thing called avoid using with dapsone because it can increase your risk of methemoglobinemia. I actually have people up at this point that we're talking up to 200 milligrams of dapsone daily and up to 200 milligrams weekly of tafenoquine, and they are on slightly higher doses of methylene blue. But the first person I can think of off the top of my head is actually on an SSRI, which everybody says you're not supposed to use for methylene blue. But whenever I talk about methylene blue, I remind people that's for IV. And if we monitor and we do things in the right doses, we can be okay. The big deal here is that's a very highly compliant patient. It's someone who's very well monitored, both by her parents, herself, and myself, with lots of labs, with lots of pulse ox, with everyday symptom reviews, every week sending them in to me. So this is just because it's the only thing that's really working, and it is working. So, you know, we avoid trying, our goal is not to harm anybody. Our goal is to help them get better. So every time we say avoid this or that, there's always going to be some exception. So if you heard, you know, your doctor's doing something that I said not to do, well, maybe there's an exception, you know, to that rule. And if, as long as they've covered that, you know, certainly work with them on that. But just be aware. So for if you're doing tafenoquine, and pretty much now this should be really becoming standard early on in Lyme diagnosis and treatment, is check a G6PD. Because if it's adequate, we're good unless you become pregnant. And then both before we start tafenoquine or dapsone, as we noticed, and during the treatments, we're going to want to check a complete blood count, a comprehensive metabolic panel, which does liver and kidney function, and we're going to look at that methemoglobin level. And these may be neat, like on dapsone, these should be done weekly. Quadruple dose, we've already gotten up to double dose, but for me, every 2 weeks when you're on below 100, if you're above 100, everybody goes every week. And then when you're on the quadruple dose, I typically will draw it the first 1 or 2 pulses after to just see how much we've hammered somebody, and then we decide what we need to do in the future. But definitely for tafenoquine, I think you should do this too, because you do see more methemoglobinemia than you would think, even at the lower doses. Then the question is, what the hell are we treating with tafenoquine, right? Because people are saying, hey, Babesia duncani is all over the place, not just the West Coast. The research shows it's on the West Coast. We have lab testing that shows it comes up on the East Coast, but when people look at those blood samples, they can never find DNA of Babesia duncani. When they look at ticks on the East Coast, they can't find it there. What they do find is Babesia otocoilii and Babesia microti. So the problem is when we look at all of this, you know, we just don't know what the heck is going on, because the problem is this is in ticks, but we've only got 2 confirmed cases ever genetically that otocoilii can be in humans. Now we have some labs that are finding it. We just need to get more details. You know, we need to have third-party validation to be sure, but it is on the East Coast. The other thing is Babesia duncani titers, both at LabCorp, Quest, MDL, IGeneX, and many other places, are coming up positive on the East Coast. Is that because the genome of Babesia duncani was only sequenced in 2016 and a lot of these labs were created, you know, tests were created before that? Is it because we really need to be looking elsewhere? You know, maybe it's just triggering it. So a lot of the researchers I've talked to say, we're not debating that Babesia something is on the East Coast in addition to microti. We just don't think it's duncani at the moment. So people are having another Babesia. We just got to find out more. So people are working on this, but in the meantime, you know, things like tafenoquine are really helping. This is just that Babesia otocoilii paper where they showed 2 patients out of 19 where they found it in a small study. So we can say there's only 2 people, but 2 out of 19 had it. So we need larger studies because it might be more prevalent than we think. But the thing here is they were actually looking at DNA sequencing, confirming that this was in fact Babesia otocoilii and not Babesia something else, giving us a false positive for a different species. So that's helpful. Tafenoquine comes in 2 brands, Aracoda and Crintafil. They have slightly different doses. Aracoda tends to be more readily available. Occasionally we can get Crintafil. Question is, where do we start with dosing? My reminder is that basically, you know, the standard dosing is the dosing that that is double the amount that gets eradication in the studies of mice. So we have a couple of options. For really, really sensitive people, we could just do 1 tablet a week and let it go up. Usually for smaller kids, we could do the preferred loading dose for smaller people. And then once a week, you could just start on twice a week and not do a loading dose. If you have a chronic infection, you want to, fly up. And then the standard way to do it is 2 tablets 3 times a day, followed by twice a week. I've done all of these. I actually prefer to do, as long as the top one is your weight, I prefer to start there, because the Herxheimer is just as bad no matter how I do it every time. And it goes away quick. It goes away in a couple of weeks, on the top one. And if I do say the very bottom or the second from the bottom, you might be having Herxheimer's for 6, 8, 9 weeks that are really significant and feeling that brain fog and fatigue from treatment. So I'm like, why don't we just get it over with, have a crappy 7 or 10 days, and then start to feel better. Now, that doesn't work for everybody, and that's just kind of a general approach, but through my experience. But there are definitely people where I still will pick and choose any of these. So just work closely with your clinician on that. Crintafil, slightly different because it's 150 milligrams. I personally don't see a reason to really go over 300 milligrams weekly, because when I do, I see increased side effects and risk. And based on the research, this is kind of approaching potentially even 30 milligrams per kilogram. It's not an exact direct measure, but we're getting in the higher doses than we've needed to eradicate this in a mouse model. And most of our infectious disease research is not done in an actual mammal model. There's almost nothing in the Lyme, Babesia, Bartonella world that's ever been done in a mammal model to show cure, right? We've seen Monica Embers do it, and we've seen Chukri Ben-Mamoun's lab, which did the tefenaquine research. We need more of that. But when we have good evidence, let's look at it, right? So the way I use it is I use it by itself. I use it a lot with the atovaquone or the Malarone, that atovaquone proguanil. I may do that plus atovaquone and things like azithromycin or chlorothromycin. And then a lot of the herbs that we talked about last time and are summarized in that freebie that I told you guys to pick up at the beginning of the call, that's there as well. So these are important things to consider. When I look at Artemisia derivatives, artesunate, if you can find it, great. It's super expensive. So I'm typically doing whole leaf Artemisia when I do that, because I don't think we covered these dosings before, which is why I had to put them here. And really our goal is to get somewhere in the neighborhood of 800 to 1,000 milligrams a day, right? I mean, some people recommend those lower doses, but that's really the target we want. If we have liposomal artemisinin, we've got 2 mouse studies showing 4 to 5 times respectively absorbability here out of the gut, so we can use lower dosing. And then we do, because Artemisia is artemisinin, is an extract from Artemisia, we want to give you a little bit of a break from it and not piss off your liver. Whole leaf, so we pulse it. Whole leaf Artemisia doesn't tend to need that. As a review, some of the things we talked about, the dosing of the Cryptolepis and the Scutellaria are there for people to review, and you can see that in the replay. We have the same, this one adds on methylene blue, because a lot of times I am doing either just with tefenaquine or with all these other combinations at methylene blue to minimize that risk of having methemoglobinemia. The other thing is methylene blue is approved for treatment of methemoglobinemia, but it's meant to be as temporary in these higher doses. We see in Lyme disease and Bartonella a lot of evidence that it can be effective both alone and then in Bartonella in combination with things like azithromycin and rifampin, and making sure that we, in eradicating Bartonella biofilms and Bartonella stationary forms. It's a couple different resources show different half-lives, but it's not super long. If you take it orally, very bioavailable, gets through the blood-brain barrier. Within 3 to 5 days, you're going to be at a steady state. It's going to be at a beautiful level. And really, the thing is, it concentrates in the mitochondria. And so any tissue that has a lot of mitochondria, pretty much all tissues have mitochondria, but things like the heart and the brain and other things like that and muscles really need a lot. So they have that. You're going to get a lot of electrons being donated from methylene blue to the mitochondria, helping with energy, helping with intracellular detoxification, and it's also going to be killing things. And so we see these different studies from Dr. Zhang's lab talking about the effect in Lyme and in Bartonella. Just throw them up there so that you know where I'm getting my research from. one of the things that's interesting is it's the world's first commercially available anti-malarial drug, but it's not been shown to be effective for any of these Babesias at the top in vitro. Thankfully, we don't know of them as human infections, but they did try it at doses up to 50 milligrams per kilogram orally a day. And most of us are using like much, much lower doses, like even at a high dose, we're still talking 4.5 milligrams per kilogram. And it did not, in a mouse model, kill Babesia microti. I like to remind everybody is lower doses of this do a great job of helping you feel better. It's an antioxidant and it gives you energy and detoxification support. So we do use it to minimize the risk of or to treat methemoglobinemia. When we're using it for Bartonella and to minimize that risk, we're starting, 25, 50 milligrams twice a day. As we go into maybe higher doses of the dapsone, we have the reference of using higher doses, right? I've actually found that a lot of people need 5 or 10 milligrams a day for months to even a year to revitalize their mitochondria, improve intracellular detoxification, which we call autophagy, to get the body ready to accept these more aggressive treatments. So in super sensitive patients and really people who are really toxic and have really low energy, I start there, right? And then the other thing is, again, do the milligrams per kilograms, because over 7 milligrams per kilogram, we can have some really serious side effects. And even 300 milligrams a day, you rarely need to go over that. And if you're looking at someone who's 70 kilos or just over 140 pounds, you're still just talking 4 milligrams per kilogram, like I said. So we really would like to be in the 0.5 to 1 milligram per kilogram range to really optimize what's going on with the mitochondria. But there's also another reason we want to do that. Methylene blue is very sensitive to being photoactivated with red light, 660 nanometer red light to be specific. This is what I use. This is actually me back in December. I cracked a tooth somehow. I'd had my mercury amalgams removed like over a decade ago. And, one of them apparently cracked. And I had to have an emergency surgery and my family wasn't around. Red light directly brings down inflammation, promotes healing, and in and of itself provides energy to the mitochondria and also brings down infectious load and things of that nature. The other thing is it will also really bring down inflammation. So that's an important one too. And I realize I don't have that link to paste for you, so I will get it as I talk. But the really important thing to me with methylene blue, and where it's really super kind of a really interesting thing, is I can give you like 10 milligrams a day, and that will be antioxidant, right? That's really important. And that will be giving you electrons to promote that detoxification, to promote the intracellular energy, to improve the detoxification and promote mitochondria, not only getting electrons to provide energy, but healing dysfunctional parts of the mitochondrial chain. So what's really important to me is that we take an advantage of that. And we also know that if we photoactivate our methylene blue, what ends up happening is that we go and it becomes antifungal, antiviral, antibacterial, and all those things. So anti-Ebola, anti-HIV, anti-Hep C, anti-SARS-CoV-1, and all those kind of things there. So yeah, and Therasage is giving you a nice 20% off, and they will upgrade with that link as well. They're super good. And if for some reason, if you go over there and they're not giving you the 20% with that link, just make sure you use the discount code Dr. Tom 20. They had previously turned it off, but they turned it back on for me because I think you guys should save. The beauty too is this is I like being able to wrap it around knees and ankles and obviously heads and things of that nature. And they're just great. They actually started the company to help their daughter get better from chronic Lyme disease. So they understand everything that everybody's going through. So I think that's really, really important. And then support people who are supporting ourselves. I'm going to go real quick over here to YouTube, and it's not letting me scroll down for whatever reason in the chat. Let's see if we can do the chat real quick here. I just wanted to say, Therasage. I'm just going to drop this in there for everybody who's over on YouTube. Thanks for joining us there. Like I said, that really helps us a tremendous amount getting this out. So then, now that I do all this, how do I use it? Well, I typically start with the age-based dose of tafenoquine and load it, and then I add to their existing protocol, just like Dr. Horowitz talked about adding the quadruple dose dapsone to their existing protocol. I use things like the herbs we talked about, but I also use BAB 1, 2, and 3 from Beyond Balance, ABAB, and Crypto Plus. So we use a lot of these. And then a lot of times, whenever I put in methylene blue, I love having the red light. Like I said, my favorite place to put the red light when you don't have a broken tooth that just got pulled is actually over the belly. That way you get the 70-80% of your immune cells. You get such huge amount of blood vessels, including the aorta. So you're really cleansing the blood and invigorating it. And then you're getting the entire solar plexus, all of that below the diaphragm nervous system, and you're directly calming it down. So it's super helpful. And that's a great place to put it. If you ever come hang out in any of our physician meetings and, business meetings, there's probably 50% of my friends and I are we actually have the red light on as we're talking. And so you see all these people lit up. You can literally just, in the morning when I'm doing paperwork and stuff, I just put it on my desk and let it shine on me. As long as you don't stare directly at it for too long, it's not like a laser that's going to burn your eye. And, it's just a great panel. So again, last piece on tafenoquine. The available evidence isn't perfect, but it's a great starting place. So before utilizing really high doses of tafenoquine or even methylene blue, because there can be some really significant side effects, ask yourself, do you know what this little animal is? And the answer is it's a lemming. And my thing is, let's not be the human lemmings who just follow other people because they say higher doses are better. Sometimes higher doses are better, but a lot of times they just lead you to falling off the cliff. So I really want people to know that they can be safe at lower doses. And they're actually, the standard doses of tafenoquine are actually quite high compared to what actually works in a mouse. So there you have it. We kind of went over that cutting edge care. We're looking at disulfiram, dapsone in a gazillion different doses, tafenoquine, and a little bit on methylene blue, so we can talk about the treatment protocols and really some of those advanced things. And really, these are the ones that really should be you should be working with a highly trained clinician on. And that's really why we have the Lyme Disease Practitioner Certification Program, over at the LDPC.com to help people get to that place so they don't have, if you're their patient, they don't have to wait a year and a half for them to figure it all out. We can help them within a week or two be really up to speed and have their back. And it's a great community. Next week, June 6th, 8 p.m. Eastern, 5 p.m. Pacific, we're going to do Breaking Free. We're going to talk about fight, flight, or freeze, polyvagal, limbic retraining, and all that kind of stuff. And then I'm going to share with you a couple of things that I do personally and I use with my patients for all those amazing results to help people get better. So with that, I see a lot of really awesome questions. So Kathy, the big thing for getting the replays is if you head over to YouTube, I will grab it for you real quick. We have the playlist and it is already there now. And we put up an edited one as well. That'll be up in about a day and a half, but I will give you the link to the playlist where everything is. If you give me just a second, I just got to get it to open so I can get you the link. Here is the replays link, I should say. This has all of them up there. Currently, we have week 1, week 2, week 3. If you want to, you can go over to the live section. If for some reason you want to rewatch today's before it's up there in the next little bit, you'll be able to head on over to the tab that says live, and that'll get it for you there. Roberta was saying that disulfiram was a great treatment for her. She was able to split the tablets. And yeah, it's interesting that sulfur-based compounds, I actually trained a lot with, are really helpful along with other antibiotics to eradicate some of these microbes. I trained a lot with Dr. Jones. We saw a lot of kids, really hard to get rifampin into a little kid without compounding it. And some people, it's just too expensive. So we could get liquid Bactrim. We use a lot of azithromycin and Bactrim with great results. Quick question on, have I ever cured babesiosis with no relapse without tafenoquine? I've cured my own babesia without relapse. I haven't had a symptom. God, it's been almost 13 years now. So for me, it was the standard meds, and then it was ABAB. So I find the herbs work really good. I've certainly done it with patients as well. So Thomas, great name, and thanks for the awesome question. Let's see, the Nikki electrical band. I don't know a lot about them. They're kind of like, if I'm not mistaken, they're kind of the upgraded version of the Wave. And so I looked at that. It was okay. I know some people who really love it. Some good dear friends of mine really like it. I didn't find it do too much for me or for their patients. That's the previous model. So maybe it's been upgraded. The replay link goes to Therasage. Oh, did I drop the wrong? Sorry, I didn't. Oh my goodness. I copied it over here and it didn't work. I apologize about that. Let me try one more time. Thanks for letting me know. All right. That one looks like YouTube. Yeah. And Wave 1, I mean, here's the thing. I know people that love Wave 1. And I know people where it didn't do anything. So I'm always trying to give you what's the highest yield for the most number of people. Something's always going to work. I had a patient early in my career who used autologous urine and cured herself. I know a lot of people who use Rife, but I don't see the consistent results for everybody. SOT therapy has been discussed over and over. I think we might have even talked about it earlier in the month. Marty Ross did a great article. It doesn't even make sense that it would work for Lyme. Maybe for Bartonella, but it makes a lot of sense in other things. Yet there's all these people doing it. I know why doctors do it, because it gives people hope and they make a ton of cash on it. But does it work for some people? Absolutely. I've seen it turn, one out of like the 30 people I know have done it had amazing result, but the other 29 just lost a lot of money. So it's about finding out those that are most likely to work and kind of go from there. Oh, you know what? Michelle told me that I forgot to add in ivermectin. I will say I've been a little bit scattered because even though I'm back home, I'm still on the phone with my mom every single day. But it's not just, it's social. It's getting her all set at the, getting her between the rehab and the new place and everything. So I apologize. Ivermectin's interesting because a lot of people, one, it's a great immune modulator. And so a lot of times we use it just for that. There is a little bit of evidence on ivermectin that shows that it may have activity against babesiosis. So it's kind of like disulfiram, right? There's a little bit of petri dish evidence, and then we start to use it clinically. And in some people with babesia, we certainly can add that in. The other thing is, my question is why I don't think that as many people have parasites as a lot of people on the internet tell you do. And even friends of mine are constantly saying parasites are causing everything. I don't know about that. I think there are more people have parasitic infections than a lot of medicine wants to admit. But I also think that a lot of people have normal parasites in their microbiome. In fact, we use Helminth parasites to support people's microbiome because they're natural. But I don't think parasites are just eating society alive personally. Now, Lyme as a bioenergetic pathogen, bioenergetic parasite, I'll talk about next week. That's important to me, because I think it acts like a parasite, and there's a lot of reasons for that. So we'll talk about that next week. However, I do find ivermectin really can help for a lot of people. I talked to Steve Phillips years ago. There's this ivermectin is used in river blindness, and river blindness has a form where like every 6 months you have to treat it. The bleb form or the granule form, one of those of Lyme, may be similar to that, and that might be why it could work. But I think more importantly is when we look at the ticks that we're finding like an Ixodes scapularis nematode in deer ticks in Connecticut and New York. I've never heard of anyone being able to confirm a human infection, but maybe we're not looking at these weird crazy parasites like pooping out a whole bowl of parasites or whatever. Maybe it's this nematode that we're getting from a tick bite. I don't know. It's in there, just like Rickettsia burkneri. But like I said, with otocoilii, that's in a deer tick too. And people are saying it's not a human pathogen, except for a handful of us saying it might be. Challenge is, but Borrelia miyamotoi was known to be in deer ticks, very similar genetically to Borrelia burgdorferi, which causes Lyme. And we've known that for over 30 years. And it wasn't until, 2012 into 14 that we said it's a human infection. I'm like, it's a Borrelia species in the same damn tick that gives you Lyme. How's it not going to be transmitted? Granted, what I just said isn't the most scientifically valid thing, but we do need to consider the fact that it could be. And so that nematode might be one of the other reasons ivermectin works. So I've actually, same thing with a lot of what I've seen. I used to do up to 48 milligrams a day of ivermectin. I found, no need to ever really go above like 12, occasionally a little bit more milligrams in a day. But a lot of my folks are doing like I said, like 3 milligrams twice a day, maybe, 6 milligrams twice a day. And a lot of them start at 1 a day. And I look at it as an immune modulator that may work in all these other things. And it's got a really great safety profile. It works, decent. And I haven't seen a lot of the nasty side effects come up. So, it works good. Yeah. And, Roberta's saying ivermectin, praziquantel. There's all kinds of stuff out there, that we can use. Some, the praziquantel can be really nasty and dangerous. Ivermectin, not so bad. Looking at the half-life being shorter, short half-life oftentimes means we need to dose more frequently. But even amoxicillin, we used to always do it 4 times a day. Now almost all the time we do it 3 to, often 2 times a day, even in a regular acting form. I have certainly been trained and utilized 4 time a day protocols in ivermectin, but like I said, a lot of people can just get away with doing it twice a day. 10-pass ozone. I don't use a lot of ozone. I haven't really seen it do a lot. I know I've talked a bit about this before, and when I chat with Neil Nathan, he doesn't find it really works well for mold. It may help in Lyme, certainly more along the line of insufflation, either in your ears or in your nose or rectally. Not so much the 10-pass, although when I first got COVID, I happened to be traveling. It was like literally a week and a half before it had a name that was publicized. I went to my friend's office. I said, just do whatever you got. And she did ozone along with a whole bunch of vitamins and B complex and NAD. So I don't know what it was, but I felt like crap for about 36 hours and then I never felt better. It was like I was cured immediately. So it certainly can work. Let me scroll back here. And thank you again, Michelle, for reminding me that I forgot about that. So Joan was saying, got bitten, itchy at the bite site. Is that an allergy? You can certainly be allergic to some of the things in there, but the common thing is when a tick bites you, it has an anticoagulant so that the blood will flow and not clot, and it has an anesthetic so that hopefully you don't feel it. So a lot of people do have a mild hypersensitivity reaction to the anesthetic in the tick saliva. And so it's trying to numb it so you don't feel the pain. But in that sense, if you're one of the lucky ones with the itch, often, although not always, but often you'll actually find the tick because of that. But you can certainly develop a localized allergy. Now, this is different than like alpha-gal and stuff like that. That's from a different tick, and it's a red meat allergy. But those localized reactions are actually not uncommon. So for the TriLite panel, I typically say, look at their instructions. They say do about 20, 30 minutes a day for a week, and then you can go twice a day or more, whatever you want. But just like a lot of other things, sauna, hyperbaric, everybody's like, oh, I'll just do this much. Most of my Lyme patients, it's great to start with 5 minutes. If you do great with 5 minutes, for 2 days, then go to 10 minutes. Ultimately, about 30 minutes a day would probably be optimal. But again, it's what you can tolerate. I have certainly been known to be on a 2-hour call with it on my belly. It's not a problem if you can handle it, but somewhere in that 20 to 30 minute range is probably optimal for most people if they can get there. Yeah, great. And, would red, I think it's the question is about red light healing neuropathy. It's certainly help, right? It can improve circulation in and circulation out, meaning more toxins out, more oxygen, more nutrients in. to help regrow it. It certainly can stimulate growth and stimulate healing, bring down inflammation. So certainly it can work. Yeah, and then just again, like the methylene blue, just buyer beware, just be aware. And there are definitely ones that you can find. The one that I think Roberta posted was the one that I was talking about with my friend the other day. That does actually look like it's possible that that data sheet may be accurate. So that's really good. But again, I personally, I'm just letting you know what I would do with my daughter and my wife and my own body. I would just buy it from InfuServe and suck it up. I would skimp on something else personally. Now, granted, this is a person who's recovered from chronic Lyme, chronic babesiosis. I mean, I had them for 8 years. It took me 6.5 years to get better. I had to pay like $18 billion to have my mercury amalgams out. And now because I had all the mercury in there, they're all falling apart. I got to have all this other stuff done. We didn't know. So I'm certainly, I was hoping to, maybe get a new car sometime in the next 20 years, but I think it's going to go in my mouth. So I'm always like skeptical. I want to make sure that when I'm putting something like that in there, I want to be careful. Intravenous doxy on Lyme. I don't remember seeing any particular research on it. I think there's been some case reports published. I could be forgetting. Most of the research, especially a lot of the negative research or the poorly interpreted results of research that's been called negative, has been with IV ceftriaxone, because that's kind of the most common thing we do. There's a question on IV artesunate. It sounds... I don't have any experience with it because we really can't do it. I think maybe now a few people are finding ways to get it. I know you can certainly go. I just had a friend who went to Europe for hyperthermia and a few other treatments, and I asked how much it is, and it's like probably like somewhere, depending upon who you are, for 2 people, between 20 and 50 grand, depending upon what you get and how sick you are. And my challenge is, are these people better? And like SOT therapy, super expensive. Are people better? I was told you can get better from Bartonella 6 months sooner. I'm like, well, that's great, but how do I know when you were going to get better from Bartonella otherwise, right? And so the challenge is a lot of these treatments are not studied. The other challenge is very few people are funding them, and I mean, there's not a lot of money to be made for big pharma at the scale they want, so they're not funding it. So we really need to rely on places like Global Lyme Alliance and such in order to cover a lot of those things. So Teasel is really actually interesting. I actually haven't seen it recommended as a homeopathic. That's kind of an interesting concept. You'd have to do a hell of a lot of dilution, but you could potentially do it. Teasel is Dipsacus or teasel root. I don't think it works for Lyme too well, but I'll be 100% transparent why. I know a lot of naturopaths who use it as one of their primary herbal treatments, and they send me a few people. The people they send me, Teasel typically didn't work, or it blows them up and they just flare constantly, and it's this never-ending cycle. But what I do know is they don't send me all their patients. They send me like 5-10% of their patients who are really bad chronic Lyme cases. So I know that it's working for somebody. I'm just not seeing people it is, because they're already being treated by my colleagues with that. And if it works, they're not coming to see me. So I do recognize that some of those things are like that. So, but Teasel certainly is one of the old school ones that people have used for a really long time. Bonus materials. Let's see. I'm wondering about that bonus material we're talking about. If it's the link here, I can definitely get that one for you. If those materials that I was talking about, those top 5 herbs for healing chronic Lyme, chronic Lyme will be here. So hopefully, that actually looks like I did put the right link in. How would you know if you're having a problem tolerating red light? We got a question on YouTube. Thanks, James. The biggest thing is, flare of symptoms. It's kind of like a lot of our other things. If we're treating a little too quickly, we can run into that scenario of we're getting more fatigue, more brain fog. The joints are worse. Like, as an example, I wanted to see if it really worked. the first day I got the thing, because everybody's got a red light panel. Juves are like $2,000. Some, Red Light Co is like 900 some bucks or 800 bucks, and they're all metal and you can't move them around your body that easily. But I have a knee that's been a little bit tricky since high school, swells up every once in a while. Kind of know what's kind of going on these days. And I put it on for like 90 minutes straight the first day. And I was expecting it to feel like crap the next day, and it swelled up, and it certainly did. The cool part was, and that was non-infectious, right? So that's just more musculoskeletal trauma and stuff. But the cool part about it was after about 36 hours, I felt phenomenal. And my knee's been really way better. So you really can overdo it by just too much time. And if you have active infections, it's going to be more like you're feeling that Herxheimer, where your classic group of, constellation of symptoms gets worse, and things like that. So thanks very much for that question. And Teasel with no results. A lot of people try different things. To Sally's point, there's definitely a bit about I just saw your other comment. Thank you. I'll get there in a second. Depending upon what you do is it is dose dependent. Sometimes it's extract dependent, or whether it's glycerin extract, alcohol-based tincture, how many times a day you did it. I think that's really good. One of the things that is really, really important about these herbs is they should probably be used a minimum of 3 times a day. A lot of these single herbs that are in tincture form. And I have a whole bunch of people that are doing it twice a day. They got a little better, and they're like, do I really need to do it 3 times a day? Yep, if you want to get better. And almost always, if they dose it 3 and even sometimes 4 times a day, depending upon the product and what the recommendations are, they're going to get a hell of a lot better when they use it that way. So that's the important part. We really do need to look at that. And then, yes, Sally was asking about my fingernails. My daughter painted both hers, her mother's, and my fingernails the other day. I am going to be cruising off to a professional conference tomorrow morning to present on oral health and how it impacts the brain and Lyme and the gut and everything. So next time you see me, the nails may not be colored this really cool green that matches my mountain bike. But, hey, when you have a lovely 14-year-old, it's no big deal. It's kind of cool. If I do natural treatments, as soon as I get a tick bite, like eating 3 cloves of garlic, raw garlic every day, olive leaf extract, biocidin sprays every day for 2 weeks should be adequate to keep Lyme and tick-borne from developing and becoming dormant. I think the sooner you get those treatments on, the better. I like those natural treatments. I personally would probably go with stuff that we have a little more evidence for currently. I would probably do those. I would be doing 2 or 3 pumps of biocidin LSF, the liposomal form, probably 3 times a day, 4 times a day. And I'd be doing cryptolepis, Japanese knotweed, cat's claw, and Chinese skullcap, and just blasting those. So I would definitely do it kind of early. And thanks for that question, Karen. I know that was from an hour and a half ago, just getting over to the Q&A box. Body's highly sensitive, and then financial constraints, using tactile technology, inexpensive and easy, this super patch. I don't remember hearing about that one, although I'm going to look at the link real quick to take a peek. I don't remember this one. I mean, there's so many different ones out there. So the thing I find is I'm really interested in stuff that if it's low risk and it might work and it's inexpensive, and it's not going to harm anybody, it might be worth trying, and so it's just about finding stuff that makes sense. And also, I think it's about finding out what the hell works for you. I think that there's a big piece of individuality, and we see that in Dr. Horowitz's study, we see that in Dr. Ligner's study, and certainly in everything I talk about and everything I do, we see that. So certainly, it'd be reasonable to check something out, especially anytime we can stimulate. If I read into that quickly, properly, anytime we can stimulate the body and the nervous system in kind of in a non-toxic way and get it to come back on track with its natural healing, I mean, it's good stuff. Do I adjust for people with NTHR deficiency? I assume everybody I'm seeing has it, and I just don't overload them. I try to keep them off of synthetic. Well, that's a tough word. Off of folic acid, I should say, because a lot of our vitamins are synthetic, even if they're naturally synthetic. And then, you know, but when we're doing stuff like, you know, Dapsone and stuff, it doesn't matter. I mean, you need to be on such a high dose. And they're getting so beat up anyway that they're barely even going to know that stuff. You know, and certainly, you know, cytochrome P450 and all these other CYP genes are things to potentially consider in a person where it seems to be active. You know, I don't spend a lot of time on specific genes in most people, but in some people I spend a lot of time on that. And that's because they've proven that they kind of need that kind of stuff. And unfortunately, you know, yeah, I have a few people who also found out the hard way and almost end up in the hospital because screening is not the easiest thing. And even if I do a lot of genetic screening at a higher level, we don't end up picking up a lot of these things until people have reactions, and it's a challenge. So hopefully we're going to continue to get better and better at that as well. The mechanism of action of methylene blue, boy, that's almost like a whole... It's funny. MAPS, the autism group, asked me to talk on Lyme, Bartonella, and methylene blue, and I said yes. I thought they wanted like 5 or 10 minutes on methylene blue as part of the Lyme Bartonella lecture, and they gave me a whole hour on it. I was like, oh my god, like there's just like literally no way, you know, I just like I'll ever find an hour. And then I did an hour for them, and then I had to go back and I found at least an hour's worth of stuff. And then I went over to iLabs to do a 30-minute one. And it was the hardest thing to do methylene blue without having, you know, without all of that stuff. So, sorry, I just the wrong button here. Trying to see if I have a quick thing to show you. If I do, it's great. If I don't, I may have to show you in the future. And this is Lyme and co-infections. That is not the right one. That's what happens when you change your computers. I don't know that I have the thing. So basically methylene blue, oh, here we go. We might have found it. Methylene blue has the ability to, give me a second. I have to move 100 screens here too. There we go. Now let me just see if I can find this for you. Methylene blue has a couple of different bigger mechanisms, and one of them is this one here, where it basically is a shuttle, right? So you have oxidized methylene blue, and it basically takes NADPH and grabs that electron, and then now we have this leucomethylene blue, and then leucomethylene blue will come over here with find methemoglobin. So it's really ferric and ferrous hemoglobin. That's the problem in methemoglobinemia. So this is the bad one, and it's in a 3+ state. So we need to grab that electron back, and you know, we shuttle it, and it just keeps shuttling it back and forth, so that then we reduce this, and that's pretty much you know, how it works, at least for methemoglobinemia, is just kind of taking oxidized methemoglobin, reducing it down to hemoglobin. And then let me see if I can find. This is all the stuff on Bartonella that we skimmed over. So, and just a couple other quick points on methylene blue. At a dose of 2 milligrams or less, it pretty much releases nitric oxide, leading to vasodilation, which is a little weird. And actually, my buddy Marty Ross called me on this at iLabs because I forgot to put this down at the bottom. I kind of deleted it somehow because it's a really hard reference to find, because we do use it you know, as in cardiogenic shock and stuff to vasoconstrict in higher doses, but it does release nitric oxide at lower doses. And then it really reverses mitochondrial damage. And this is that thing I was talking about, and I kind of skimmed over earlier. There's 5 respiratory complexes in the mitochondrial chain, and complex 1 and 2 are frequently become dysfunctional. This can drop electrons into 3 and start getting energy at the tail end, as it's got the ability to also help potentially reverse the damage done in complex 1 and 2. So it's very helpful, but this is really lower dose, right? So when we're talking about at 300 milligrams total in a day, we're already at almost, over 4 milligrams per kilogram. So something to think about. And again, like I said earlier, it really concentrates a lot in these tissues of most mitochondria, including some of the most important ones like our liver, kidney, our brain, and our heart. And then again, dropping electrons into the electron transport chain, but it also increases cytochrome oxidase function and doing all these kind of things. I think I have this slide in that other deck. And then this is where it gets kind of interesting. As it donates electrons, or as the dose gets higher and it donates more electrons, it becomes a bit of a pro-oxidant, right? And so it does actually generate these peroxide radicals and stuff. So it'll, instead of being antioxidant, becomes pro-oxidant and generates free radicals. So it's something to be aware of. And this is potentially the reason that we see that 660 nanometer light working. And then basically when you get to super high doses, it's really dangerous. So hopefully that's a little bit of extra on methylene blue. But really the way it works for methemoglobinemia is that being an electron shuttle and going from oxidized methemoglobin to reduced hemoglobin. So thanks for that question. Yeah, side effects and risks of arsenic. Not really sure what the question's all about. I certainly would not be ingesting personally arsenic, as it is toxic. I mean, certainly we do get it on some food sources, but I'd probably steer clear unless there's something I'm missing about that one. If you certainly please let me know. Burning feet, or is burning skin in the feet and arms a possible sign of Bartonella? Yeah, I mean, Bartonella can do that. I think I saw a question about let's see, we've got a neuropathy and stuff over there, but yeah, any kind of neuropathic numbness and tingling symptom could be related to Bartonella, could be related to yeast and mold. It could be related to heavy metal toxicity. It could be related to diabetes and sugar issues, and demyelination of nerves, but definitely Bartonella, I see there too. And a lot of people, interesting. Yeah, Alinea is a really good, potentially anti-Babesia. They were going to actually study it in Babesia because it's great for SIBO too and great for parasites in the gut. But Alinea was going to be studied for babesiosis, and then they got an approval for acute flu, and they got fast-tracked for that approval from the FDA, and they had to go down that track first. So hopefully they'll be looking there. And part of that small fiber neuropathy, we can use things like peptides, like thymosin alpha-1 to help in there. IVIG can help if it's biopsy proven and of a certain type. Certainly anybody with neuropathic type symptoms, I'm using higher doses of B vitamins as activated methylated versions. So those are all good ones there. Yeah, Buhner, I challenge, Buhner is interesting. Buhner is an amazing researcher. Was an amazing researcher, but not a clinician. So a lot of what we're seeing is he's saying to use certain herbs for certain reasons. And when we study it, like at Johns Hopkins and other places, we're not seeing that that's the case. Like Alcornia is supposed to be great in Babesia, but it didn't really come up being high at all in those studies. But a lot of my friends are still saying, hey, it's a tonic for the red cells. Well, why not add it? So same thing with like astragalus and other things. It's really like, is it going to prevent Lyme? Based on the research I've read, no. Is it going to help your immune system fight off Lyme if you get it, so you don't, so that you basically kill it and you're good? It's much more likely to do that than actually kill it based on the research that's out there. So interesting. And then, what's the duration I said to treat Bartonella with antibiotics? I hopefully haven't said any, because I usually start people with a 4-week course of treatment and reassess. And then reassess every 4 to 8 weeks and treat them as long as they're, as long as they're symptomatic and they're improving. And that doesn't mean there's not times where they're going backwards or sideways or where they have a little plateau and we have to switch things around, but we need to move that up. And thanks for the clarification, Roberta. But there's a lot of stuff they're saying, like, all of us say treat Babesia with artemisinin. If you look at the study on Babesia Duncani, artemisinin does a little. It's like 60%, which is good, but or maybe 50. I don't remember the number off the top of my head, but it's not all that great. It's not all that bad. It's just not like the be all end all that we've been talking about. So that's really important stuff. Let's see. Acupuncture. I think it's great if you get a great doctor. I've seen some acupuncturists that can like split the cosmos. They are so precise and they do such a good job. It's like everything. I mean, finding a good manual therapist, body worker, whatever. I don't want to insult any acupuncturists if they not considered body workers, but people who work manually with the body and they're moving energy, not necessarily by taking stuff, but by moving things. It can be huge. It's why Neil Nathan and myself always say, like, hey, go find a cranial osteopath. And if you can't find another person who's really good at moving the lymph, that getting the nervous system calmed down, there's a lot of ways to do that. Links to photoactivation of methylene blue. Let me see. That might actually be tagged in this paper. I might be able to pull it up right now. And one of the things that's really interesting for all of us who are going to hang out for next week is extinction memory improvement in methylene blue. So essentially, fear extinction decline. When you don't reinforce something, it should go away, right? So it's kind of that if you don't use it, you lose it. So if you don't reinforce a fearful stimulus, it should go away. Problem is, a lot of times it doesn't. That's why like some of your dogs are like super nervous all the time. If you give people methylene blue and you teach them that, like say limbic retraining, it works better. I mean, it's basically like this. How easy is it to unlearn being fearful? Methylene blue makes it easier. And it improves extinction memory and it improves brain metabolic activity, especially in all these cool areas that we're going to talk about next week, including limbic things and the anterior cortex and some of the temporal cortex and things of that. So, it also improves memory without messing with other things. It's kind of interesting. Memory, arousal, attention, motivation. Let's see. We were trying to find photoactivation here, so give me a second to scroll. Boom. Yep, and it's not on this slide deck. I will see if I can remember to post that for you, because there are a bunch of articles on that, so it's good stuff. Activation. Let me see if I can find the one that I used for that one. But there's a bunch of different studies, so we'll see. I'll come back to that if I can get it. So can you speak about the treatment of species form of Bartonella, no other infection, Bartonella? I think this is a couple of things. Bartonella, like with Babesia duncani and Mycroti, we think there's different ways to treat it because we have evidence supporting that, right? The challenge is, how do we... Bartonella, we think we treat all the species the same. So when we look at that, we know that from the research, it's very similar genetically to brucellosis. So a lot of the evidence that we know for how to treat Bartonella starts to come out of brucellosis, where I think I said this last time, we've got, if we treat with doxycycline for 6 weeks, the standard of care, we've got something like a 50% relapse rate. If we treat with doxy and Bactrim, or doxy and rifampin for about 10 months, you'll get still somewhere close approaching 20% relapse rate. And if you treat with doxy, Bactrim, rifampin for 18 months, you get less than 5% relapse rate, at least with antibiotics. So that's what we know about that time. So most of us are going to talk about double intracellular coverage, meaning we'll do like a macrolide, like a clarithromycin or an azithromycin plus rifampin, Bactrim, minocycline, doxycycline, something like that, because there is evidence that in as little as 2 generations, at least in a test tube, Bartonella can become resistant to azithromycin. So a lot of people have done work where we put them together. IV doxycycline and other, in combination with other medicines, has actually been used in Bartonella endocarditis, because that could be a problematic one as well. So it is kind of one of those like important things to look at. And but yeah, and the duration of all these things really is a bit different, and it's interesting. Yeah, I love Bill Rawls and Dietrich. They're doing deep dives on herb findings. And I think that Rawls is really trying to pull out that stuff. But it's funny, we still make these. Everybody's making these not quite evidence-based concoctions. It's very interesting to me. But again, we don't know everything, so it's interesting. Let's see. Yeah. Do I find psychological therapy helpful? I think my friend Beth O'Hara is a world-renowned mast cell activation specialist. Number one thing she does, modulate the immune system. Modulate and address the nervous system, limbic retraining, amygdala retraining, whatever you want to call it. The stuff we're going to do next Thursday night. That's what we're talking about. But yeah, and Dr. Horowitz in his 16-point MSIDS, questionnaire 16, it used to just be psychological issues. Now it's like trauma and other psychological. Trauma is a challenge because it's real or perceived threat to oneself, leading to real symptoms, right? So it's one of the cornerstones I think that everybody should be working on as part of what they're doing. Yep, I don't know why they're not coming through. Somebody said the not answered live wasn't coming through, but maybe it's just because oh, there we go. Thanks. Yep. I just had not actually even gotten to the live Q&A just yet. The super patch. Yeah, I personally haven't. Some phone calls come through, right? I haven't personally used the super patch. I was just saying that like topical stimulation, a lot of even what we're just talking about with the cranial osteopath and the acupuncturist could work. I like things that have low risk and lower cost and some potential. So I've heard one or two people talk about them. So, it might work, but I haven't seen really, and I haven't had any direct personal experience. Daughter just removed a tick. Can you wait? Do you feel I can wait for 6 weeks? Lyme symptoms. Should she take blood work immediately? I would go back and I would look at this video right here, because we answer all of those in this one. Let me get you the link, and hopefully this time I'll copy the correct link. This is tick bite info is here. We've got, oh, nope, it did not work. This is what I did last. Sometimes the clipboard doesn't work. I apologize. Tick bite info. At least this time I saw it. There's that one. And then the other thing is, let me grab a blog post for you that addresses that. So it's more of a Cliff Note version. Let's see. Oh, that's preventing. I wasn't the right one. Here we go. Yep, here we go. This hopefully will more tick bite info. And I'll put this in the YouTube as well. So one of the questions is about, like you mentioned earlier, acidic or an alkaline environment. There's a concept, like a lot of us know that, like a lot of people talk about the alkalinizing, any diet that alkalinizes, right? Like, so infections cause the internal environment of the cell to move more towards an acidic environment. And a lot of our antibiotics do work really better in a more relatively more alkaline environment. And what we're talking about is hydroxychloroquine or Plaquenil works primarily through alkalinizing the intracellular compartment. So whether or not it works for the Lyme cyst or whatever, a lot of people are using it with things like doxycycline, minocycline, rifampin to potentially help improve their ability there. PEMF certainly can be used. There's a whole bunch of different ones out there that are possible to use. I typically have an MAS wellness version. I really like that one. I feel it works great. I feel very mixed emotions about Beamer. I think Beamer has a great marketing, and the people I know who do research on bioenergetics have a different opinion about the quality overall. So, but there are a bunch of different ones out there. At the moment, I don't have a particular favorite one. The one, I don't have mine in this room. I have a travel one. Bill, why can't I remember Bill's last name? I'll figure it out in a second. Bill Pollock. So if you go to here, I'll post this in YouTube first, because that's where they add info on PEMF. If you want to talk to like the world's, most, one of the world's experts in this. Check out Dr. Pollack. He's a good friend of mine. He has a bunch of different devices. His team will actually do consultations to help you figure out how to get the one you want. Generally speaking, a good PEMF will make you gulp when you hear the price. If it's not really expensive, it may not work. Which one is? I'm trying to find his thing because I have one I love for more like. Where are their products? It'd be really nice if they just had one product page. They have the comparison page. Let me see if I can find it. I have a travel one that I got from Bill. And I really like, let's see. Nope, that's not the right page. Oh, here we go. Because he talks about that. He really does an in-depth. So I have a Flex Pulse 2. Let me see if I can screen share real quick for you. Oops. That's the wrong screen. Here we go. Here's the Flex Pulse 2. It's more of a localized treatment device, and hence they say local systems. Oops, that was not the way we wanted to go. Sorry, I have to duck behind the camera to hopefully get this to go back. But so there's all kinds of different ones here. I have a friend who uses the Hugo, really loves it. So I would just recommend checking out Bill. And talking to him and learning more about that because he's the guy who does the most exceptional sort of work with that. So thanks very much for that question. Sorry, I just have to move a few. I have like 16 windows and they're all dangling behind a camera here. So let's go back to the questions. So methylene blue is used in the protocols I recommend, sort of like zinc and like the quercetin to kind of shuttle zinc in. It's kind of like that. But, it's a little bit more, it's specific to the mitochondria. So, but, kind of a great analogy there. Let's see. The Douglas coil popped up. I love it. I haven't heard about that in a little while. Oh, and thank you, Roberta. The breath work I taught last summer was amazing. Well, we're going to up the ante on breath work next week at the end. We're going to give you stuff you can do right in at the moment. And we're also going to make sure that you can have some quick ones that are super easy to do. And we're going to do a more in-depth one. It'll be great. Yeah, it would be nice if methylene blue could be covered by the FDA, wouldn't it be? We probably need a few more studies, but it's another thing. There's a lot of work going out. Even like one of the studies that I tried to pull up quick, I couldn't find the one I used in that paper like really fast, but they were like already right away, like, using methylene blue for COVID and other viral things. So people are really looking at that. But yeah, if you just going back to that last question, there's so many papers on photodynamics and methylene blue. If I find it, I will make sure I put it up on the replay on the YouTube page. But if you just go photo activation methylene blue, you could probably be reading for a good couple of months. Live in an area that's infected by a lot of ticks. Is anything you can take to prevent Lyme, even if you do get infected? Right now, the answer is no, without just taking like long-term antibiotics, which I don't think anybody I know really recommends. Some people in the summer will take, like a lot of times I'll have people taking MCBB2 from Beyond Balance and AL Complex from Byron White all summer if they tend to get a lot of tick bites and we want to minimize antibiotic exposure. There's a couple different groups working on vaccines, including Pfizer and Moderna. Pfizer is going a little more, best I can tell, they're doing a little more kind of standard antibiotic vaccine, and Moderna is doing a little bit more of the mRNA version. Like I might have mentioned earlier in the month, they are actually kind of open to hearing what we all have to say, but they are working on it. And they've taken the data that came out of the original vaccine, which actually worked really well, and it was more of a PR problem, but there were some things in it that could have been improved upon. So they're taking that into account. So my goal is to get them on my podcast where they can actually, take some questions. I mean, they're certainly not going to let me lambaste them, but they're really open to hearing what y'all want to know about. So what I'm going to do is, if I can get them to come out and their marketing department say it's okay, the scientists, I'm just going to basically I'm going to send out a newsletter. I'll poll everybody. So if you're on the newsletter, stay on there. I'll make sure I get it out to you. And then what I'll do is I'll send them some questions so we can have a good conversation, because they are actually I mean, obviously they're big pharma, they're trying to make money, but a lot of the researchers I talked to recently, they actually they hear that patients are suffering and they want to prevent the illness. And some people don't like vaccines and they have some concerns about it and they're skeptical of big pharma. And they're like, what can we do to listen to them and also to help and support? So hopefully that'll be coming out. Last I heard, based upon where they're at, they're expecting, if all goes quote unquote well, to be rolling out vaccinations for Lyme disease within 3 years. Let's see. Yeah, just a question about MTHFR SNPs. Is interesting. I was listening to Peter Attia the other day. He's a longevity guy, and he's just talking he's like he doesn't even check for MTHFR anymore because almost everybody has it, and having SNPs for C677T or A1290, 1298C is pretty much the wild type, right? We call the not having those mutations wild type, meaning that's how quote unquote normal people are in the environment. But the reality is most people have something. So because it's becoming more normal, it's the biggest problem. I mean, and I don't want to offend someone like, Ben Lynch or Amy Yasko who dive deep into this. There's a role for people who are super sensitive to really micromanage this. But the point is we should be bypassing these dysfunctional, reductase enzymes and all this other junk and giving people methylated B12 and methylated folate does that. If you happen to be cranked up by high doses of B vitamins, that's different. So I would just say be careful with it and always, I don't think the methylated form necessarily needs to be avoided. I would avoid the synthetic folic acid that backs up. So what I see is a lot of people will have a, homozygous 677T, and then they have a normal folate level. And you're like, oh, everything's great. And granted, this is mostly the people who don't know and not all of us. But, the reason the folate's so good is because you're taking a bunch of synthetic folic acid, or you have food added, food that's folic acid added. And that's a place where I see a lot of people getting messed up, is it's in their food. So that's why we don't want all these processed foods. But folic acid looks good in the blood because it's not getting pushed past. It's just backing up. So that's something I'd be, concerned about. Yeah, and activated B12. Hey, I mean, I love methyl B12, but if I can get methyl adenyl, adenosine, and hydroxycobalamin, I would just take it just because it's less steps to break down. That's really the big thing. So great question. Thank you. Microbiome breakdown testing. I don't know that I know what you're talking about, Abraham, other than you could certainly get different, you can get different things like on your Genova stool test. You can see different metabolic breakdown products and other things like that. So best herb for mycoplasma. Oh, yeah, that would be great. I got to tell you, the thing that I love the most for mycoplasma, aside from doxycycline and azithromycin, along with some NAC, is Byron White's A-Myco. I've seen that work some gangbusters. So not to say there aren't others, but the one that I've seen the best results with is there. I do not treat patients in Wisconsin. If I am not mistaken, one of our LDPC practitioners is in Wisconsin and is awesome. Let me just double check that that's true, because I remember a lot of stuff. Where is Clemma Nash is, if I'm not mistaken, she has a license in Wisconsin, and she is awesome. So I will give you her thing. Doc in Wisconsin. And Clemma works directly with me. She was in our program from the very beginning. I think I'm almost positive she's in Wisconsin. So, and so she's great. And then let me see one other thing for you, another reference potentially. Okay, yeah. And Dr. Jess does not have one there. I may be getting one in Wisconsin, part of our Interstate Medical Pact. Yeah, New York. Person I recommend the most in New York is actually Jess Montalvo, because she is actually a practitioner in our practice, and I will be getting a license. My New York license is, coming very soon. It's in process. So, and then that's Dr. Jess's thing. So thanks for that question. Yeah. Okay. Thank you so much, Marianne, for clarifying the arsenic question. Yeah. Methylene blue can have a little bit. What are the risks? Unless you have like zero detoxification, and you're not doing any other kind of like good diet, making sure your bowels move, maybe a little glutathione, NAC, what's the other, arlopoic acid. So I love using either glutathione or RLA in folks on methylene blue. And also I use Picana drainage remedies, homeopathics that support liver, gallbladder, kidney, and lymphatic function. It's usually, I haven't seen it be a problem. The levels are low. My point is like, you can't have none. And if you have none, you're probably lying. So then I wonder what's in there. But yeah, I think just going back to that question too, about if you're looking at, how people, totally stumped myself. That's really interesting. It's like the whole point is oh yeah, I know. It's about the limbic retraining and working on trauma and going to see the psychiatrist. I think emotional health should be a part of everything, right? And it doesn't mean that working on optimizing your emotional health is a bad idea, is because you have a problem. It's just because it's part of body, mind, and spirit is literally how the body functions. But the thing is, the human triune nature of body, mind, and spirit doesn't understand separate. Our brain can talk about separate, and that's why we all talk about it. But physiologically, you have an emotional response, a mental response, and a physiological response to everything that happens. So why not work on all of them? Same thing comes up with this. I think everybody should lead a detoxification lifestyle. So if you at least have that basic detoxification lifestyle, I have not seen, even a couple of years of methylene blue lead to major problems. With that said, I try not to keep people on methylene blue that long. I'm more worried about it dying organs long-term at higher doses and, for that duration than anything else. But let's say you did. Let's say you were on methylene blue 50 milligrams twice a day for 2 years. I would probably make sure I stayed on it a little souped up detoxification protocol for another year and a half, just to be sure. And if you're recovering like that, you probably will be as well. So super awesome questions, everybody. Thanks so very much. There was one thing Lyme foundations are funding research to interrupt tick reproduction. Veterinary science is doing amazing work. Veterinary people are doing so much. Yeah. Global Lyme Alliance is funding a ton of work in humans. There are a lot of other groups who are. The thing is, it's interesting. Bartonella is found in dog tumors. Well, Bartonella is found in cats, but cats don't transmit Bartonella to us. Cat scratches and bites transmit Bartonella to us through the feces of fleas that are on the cat. So Dr. Jones really reminded me a lot when I was studying in his office when he was still alive. And granted, he'd seen more Lyme patients than anybody ever. He said, look, we have kids where we find Lyme and Bartonella in their brain tumors. But he felt very strongly that that the Bartonella and the Lyme were not the causes of those tumors. Now, same thing goes along with the stretch marks we talked about. So I think what we would need to do is find out, are we getting things like those, a lot of the vasoproliferative lesions from Bartonella, is it, because Bartonella is present and causing it, or is it just that something happens and they move in? We know in immunosuppressed humans and animals, we will see vasoproliferation due to Bartonella. So let's get some more funding. And I think that what I would do, very least, go over to Global Lyme Alliance, hit contact us or now or whatever one there are, and just say thank you for what you do. If you have a couple bucks and you want to send them some money for research, send them a couple bucks. They will make sure it's used well. I'm on their medical advisory board that they just made a couple years ago, because they found that they had a scientific advisory board that was what all the microbiologists wanted to know about, when all the researchers wanted. Like, well, what did the patients need and what did the doctors need? And thankfully, they're asking those questions. So on top of that, and they're working with Pfizer and Moderna and all kinds of people, or at least not pushing them out. They're bringing people together. The other thing is, just a quick public service announcement too. If you have a little bit of means, whether that's $1 or $10 or $100,000, and you're like, this research is great, but you'd be like, I really would like to support a patient who's in financial need, particularly children 25 and younger. Limelight Foundation is incredible. I think it's limelightfoundation.org in Burlingame, California. They've provided over $9 million in funding, upwards of $10,000 per child and $30,000 maximum per family, for diagnosis and treatment of Lyme disease and co-infections and things of that nature. The beauty is they've set it up where they have a private organization that funds 100% of their operating costs outside of the organization. So every penny you send in, if you send in a nickel goes to a patient, right? And that's the beauty. So on the side of getting people access to care, Limelight Foundation and a lot of other people are doing great work. Global Lyme Alliance is really funding a lot of the research. And if you go to GLA, let's close on that, because I know we're running way late here, and really excited to share all this awesome information with everybody. And so many people hang out for so long. I love it. Thank you so very much. You're the reason I do this. You're the reason that people are like Dr. Horowitz and everyone else is able to keep going and make these huge changes for people. But if you go up here to Global Lyme Alliance, like I said, just reach out and say, hey, you guys are doing great work. Whether you can donate or not, doesn't matter. Just say thanks for the work you're doing. You're making a difference. I know they care. But on this patient support page, sorry, come on. Let's see, I'll go to another one. So maybe, here we go. If they not only help with different support things, they have their financial aid page. So if you go to financial support, you can start to see different things in New York, Connecticut, other states. Lyme Aid for Kids can give them $1,000. Limelight Foundation obviously is the one I just talked about, and you can just go to limelightfoundation.org. Lyme Test Access Program is really important, and on and on. So they've got a lot more, even help with getting medical bills paid for and meds. The other thing though is they do have, I don't know why my thing's not working today, so I'll scroll down this way. They do have a peer-to-peer support program. They have group programs that they can help get you in touch with, and a Lyme symptom tracker so that you can track your daily symptoms as well as your activity. And then you can go see, their clinical trials and such, and that's up over here, which looks like it's working now. So hopefully that's a really great resource for everyone. I think it's really important for those guys. And yeah, you're very welcome. Thank you all for all those kind of things. And just to close that, detoxification lifestyle is peeing, pooping, eating water, drinking water with electrolytes in it, breathing properly, doing some exercise, getting some sleep, eating, whole food, plant-based diet, with a lot of veggies first, adding on your proteins and leaving the rest of your carbs to the end. Just the basics of a good, healthy diet. There's so much information on that these days, so it's really helpful. And just want to say thank you to everybody for joining us. I will see you next week, not on Wednesday, but on Thursday, June 6th, 8 p.m. Eastern. We'll start off talking about fight, flight, or freeze, limbic and vagus stuff, retraining, give you some simple exercises you can use and start using immediately. We'll do a group healing session, which will be recorded, and we're going to post it both in the live, and then we'll clip it out and post it for you afterwards, so you can use it as a standalone healing session as often as you want. I would recommend daily. And then after that, we'll hit our little bit more Q&A, and I will see you next time. Thanks, everyone.